Thank you all for being here. On behalf of Mehdi, Erin, Paul, Manas, and myself, thank you for being here and the inaugural CVI 2017. Probably thank you, Mehdi, for this 7-minute talk on high-impact publications for the entire year. And unless I limited myself to the years 2016 and only focused on randomized and prospectively collected, independently adjudicated data, I would never get past it. Don't see it. Okay, here it is. You know, the fact that a CLI, high-impact publications, can be given in 7 minutes, this is not a pun, but probably a call to action. And I think many in this room have contributed to this area. And I can tell you that all the cardiovascular, surgical, and interventional radiology and vascular surgical meetings we attend, this has become a topic of intense conversation. And I think that is the beginning. So let me take you down a few high-impact publications. The first one I want to focus on is the Liberty 360 study. I just want to also preface that I've left out large-scale epidemiologic studies because Dr. Michael Jaff did a fantastic job addressing them. These are mainly therapeutic studies. The key reason why I selected this study because it was multi-center, however it was observational, but it was prospectively collected, and it included a large number of patients with Rutherford category 6, 4, and 5. It was also independently adjudicated by 4 independent core laboratories. This was presented by Dr. Jihad Mustafa at AMP last year, and we're still awaiting a published report on this. The key factor here are that at 30 days, they reported a 2% procedural complication. This refers to a 78% discharge home for Rutherford category 6 patient. This is relevant and highly significant because Dr. Michael Jaff said the degree of hospitalization and return to hospitalization within 30 days can be extremely high in these patients. Freedom from major adverse events, about 90%. Freedom from amputation at 30 days, extremely high. So is target vessel revascularization and all-cause mortality. This is why I'm looking forward to this publication. I also want to key you into this, and so look for this publication. Now, what did it matter for the patient? As you can see, they did measure objectively, and they've set a standard of how this could be done in patients with advanced symptoms. Total score in terms of quality of life, VASCOL, physical activity scores, symptom domain scores, pain scores, and emotional activity scores, and social activity scores are all being measured. And I think this would set a standard of how future CLI studies are done in terms of measuring patient-centered outcomes. Let's switch gears and take you down to Europe. And please reflect on the enormous effort these investigators have put. Can you imagine multinational CLI study of Fontaine 4 patients, including 840 patients, randomized to complete ulcer healing, comparing complete ulcer healing versus major amputation, comparing aloprostadiol, which is a prostaglandin inhibitor, and placebo. This is a major initiative. Again, not surprisingly, that this large-scale trial did not show any benefit of either of these strategies. There was some marginal benefit in either group. However, this was not statistically significant. Once again proving that these kind of therapies probably may not be very useful in these patients with active ulcers. Let me take down to you, reflect upon this trial, the CABB, not single B, trial that compared the use of cilastazol after below-the-knee angioplasty in patients with CLI. Again, this was a prospective, randomized controlled trial. Of course, it was open-labeled, but the adjudication of the trial was independent and blinded. 60 patients, 38 lesions, randomized after intervention to cilastazol and placebo. Absolutely no effect, showing that cilastazol, of course, has been debunked in multiple different ways and has no role in CLI patients to improve patency or improve revascularization outcomes, and here shown in 3 months. The next trial is the Critic Registry, which is a peripheral vascular intervention versus surgery first line in CLI, something the previous speaker spoke about, and we're going to see a lot more data coming down from the NHLBI, hopefully in the next coming years. The value of this study was that there are 1,200 CLI patients from 27 centers enrolled very recently between 2013 and 14, and the first line of action was at physician discretion. As you can see, 54% patients at physician discretion, underwent PVI, and then surgery was in 24% of patients, very similar to what our previous two speakers spoke about. And as you can see, if physicians make clinical decisions, at least in a prospective, well-controlled observational study, they were pretty equivalent. This doesn't prove that these two strategies are equivalent. However, it tells us reassuringly that there are some clinical features that we can use to select either of these strategies, and we are doing probably a decent job of doing so. The next trial is the follow-up, 5-year follow-up of the PADI trial or the PADI trial. This is an infrapopliteal DES use, primarily paclitaxel DES, compared to PTA, angioplasty, and occasional and bailout use of bare metal stents in patients with CLI. 137 patients, and please pay attention, these are 5-year follow-up outcomes, 1-to-1 randomized, and 74 patients received DES and angioplasty and bare metal stent as bailout in 66% of patients. And as you can see, 5-year amputation rate, 5-year event-free survival was definitely better with DES, providing reassurance that these technologies could be developed further and utilized in clinical practice. However, let me tell you also that in the United States there are no approved infrapopliteal DES stents that are currently available. So in summary, as I have presented some high-impact trials that I felt, in my subjective opinion, were valuable, I also want to key in some fact that there are lots of studies coming in publications and being published on gene therapy and stem cell therapy. There are also novel revascularization therapies that are going to be in publication, arteriovenous stent grafts. Of course, below the knee, DCB, DES, and BVS and bioresorbable stent studies are coming. I should add here, based on this publication of studies that are going to look at perfusion imaging. But the most important two studies that I think is worth, again, repeating are the best CLI studies from the NHLBI and the Basels II study from England that I think we will see results in the next few years. Thank you very much for your attention. And thank you, everybody.